Well, I do want to thank you and welcome you today for joining us in this workshop, which I think will be an informative workshop. And I know that all of us at NIH really look forward to hearing from you on the topics of policy and ethics of record linkage. The goal of this workshop is to examine the opportunities and challenges of record linkages with a focus on privacy and security, the use of record linkages within and across different information systems. The idea is to build a more inclusive and less biased framework, and general principles and criteria that should guide the use of record linkages. We'll also have discussions on participant perspectives, researcher participants and community awareness of and expectations for record linkages, and general principles and criteria that should guide engagement with research participants. And ethical issues related to record linkage, conditions for informed consent, for example, information, roles, and responsibilities for governance of record linkage. These are just some of the topics that we'll be discussing today, and this is really an opportunity to hear from the community on these topics and to have you participate in these discussions. There's other ways for us to carry on these discussions beyond our workshop today, including a Slack channel. We'll provide the link for you. And we hope that you will engage each other and us in discussions about record linkages. In addition, NIH will offer a request for information, an RFI, on this and other related topics, which we hope to get out in the July 9th timeframe. In concordance with that RFI, we will host a separate webinar on streamlining access to controlled data at NIH, tackling challenges and identifying opportunities. This is a way to carry on a similar conversation to the one that we're carrying on today. So I hope that you will look for that webinar and consider joining that as well. I just want to go over a few process notes as we get started. This is an open session of the workshop, and this and all open sessions will be recorded, and they will be made available on the Office of Data Science Strategy website as soon as possible. The participant breakout sessions will be recorded only for note-taking purposes. Today, if you would like to pose a question to our panelists and our speakers, we ask that you use the Q&A function on the Zoom. That way we can moderate the questions and make sure that all voices are heard. Certainly, feel free to chat with your colleagues, but I believe that the hand raising and perhaps even some of the chat features may have been disabled. Again, please do use the Slack for communication. What can we expect from this workshop? After the meeting today, we will provide an executive summary of the workshop that includes discussion points that are raised at the workshop today, as well as the recording. This executive summary will help inform NIH on technical and policy issues related to record linkage. So I really want to thank you in advance for your contributions to this meeting. All voices are important, and we are happy to have all heard. And with that, I'd like to introduce our speaker. It's a real pleasure to introduce our chair of the workshop, Dr. Pilar Osorio. Dr. Osorio is a professor of law and bioethics at the University of Wisconsin-Madison, UW, and the ethics scholar in residence and ethics program lead at the UW-affiliated nonprofit Mortgage Institute for Research. With that, I am happy to turn it over to my co-chair in this workshop, Dr. Patty Brennan, for any additional words, and then to Pilar for her opening presentation.
Thank you very much, Susan. I just want to echo Susan's invitation and gratitude for all of your presence here today, and to remind you that this particular workshop is going to be incredibly informative to the NIH to learn about how to begin to think through some of the practices of record linkages and the policy and ethics associated with that. We're very much interested in hearing from the broader community. We do have many NIH staff members present, and we thank them for their work to get us to this point and their presence here. Today is about hearing from our outside community. Thanks very much, Susan. We'll turn over to Pilar now.
Thank you.
Hi, thank you. Well, hello, everybody, and welcome. So my job today is to introduce the meeting and give a high-level overview of the topics. But I first do want to just reiterate that this is an opportunity for NIH to hear from you. So please do participate. So I'm just going to start off by saying that I will give a sort of high-level overview of the topics and then hand the microphone off to colleagues who are far more knowledgeable than I on record linkage, and they'll start us off by describing record linkage in more detail, providing us with some use cases, some pros and cons, and a landscape analysis as background for the remainder of the meeting and our discussions. And we'll then have a Q&A and a break today, followed by a session on privacy and security of data linkage. After about a 10-minute introduction on that topic, people who've been assigned to breakout groups will go into their group for a 45-minute discussion. And if you've been assigned to a breakout, you should have a separate link for that. And people from Deloitte will be here to help you if you have difficulty transitioning into the breakout. All groups are going to discuss the same questions, so nobody will miss out on providing feedback. And please do speak up in your groups. After the breakouts, we'll be reunited briefly to hear a summary of each group's discussion, and that's going to be very brief. We'll then have some audience questions, and then hear some concluding comments for the day from Dr. Patricia Brannan. Tomorrow, we'll be back to talk about research participant perspectives on data linkage and about ethical issues beyond data privacy and security. So we hope you can stay with us for the entire meeting. Now, of course, we're here to talk about record linkage. So we might begin by asking, what do we mean by that? And we're going to hear a lot more about this from Dr. Alistair Thompson in the next presentation. But my way of thinking about it is as follows. Record linkage means bringing together from two or more sources of information about a person, from two or more sources, information about a person. Or it could be about a family or a place or event, but in biomedical research, we're usually thinking about linking records pertaining to an individual. So in this image here, if I am person A, then we're talking about bringing together a record about me from each of the 3 data sets so that we create a richer representation of me that researchers could use in their studies. Linkage effectively creates higher dimensional data about an individual because the linked record contains more features than any of the original data sets did alone. So it turns out that record linkage, it's not a new thing at all. It's been going on for decades and been done by many different entities and kinds of entities. It's been used by government statistical offices in pretty much every industrialized nation. It's been used by academic and non-governmental researchers who link survey responses to government administrative records. And survey methods textbooks published since the 1960s have included methods for doing this. Record linkage is being used by healthcare organizations to assess things like health needs and healthcare quality. And in biomedical research, linkage can help us to understand outcomes of using particular medical devices, for instance, including diagnostics, or the outcomes of clinical interventions. When data from clinical trials or other studies are linked to administrative data, the linked data set can enhance a research analysis, can help researchers to impute missing data, or can validate existing research data. In the domain of health policy, record linkage also has a pretty long history. And just for example, the CDC's National Center for Health Statistics has several projects that link health surveys or epidemiological data to administrative data sources pictured here. So Medicare, Medicaid, National Death Index, even housing and urban development data. And one well-known study for which the CDC does record linkage is NIH. The National Health and Nutrition Examination Survey. And you can see here that records for NIH are eligible for linkage to records from the Centers for Medicare and Medicaid Services if participants have provided consent and have provided identifiers that can be used to make the linkage. So full or partial Social Security number, for instance, and birth dates. And here's an example of an NIH-funded study that links records. It's the Health and Retirement Survey led by the University of Michigan. This study has interviews, measures of physical function, biomarkers, and DNA data. It has at least interviews for approximately 26,000 adults over age 50. And for consenting participants, the study links research data from with Social Security and Medicare claims and to employer information on pension plans. So these linkages allow researchers to produce detailed characterizations of income, wealth, and healthcare utilization over time, and to analyze how, for instance, a person's wealth or changes in wealth over time relate to measures of health. So finally, I would point out that record linkage is being widely used in commercial contexts. Google, Twitter, credit data, location data from cell phones, and other data is bought and sold by commercial entities and is routinely linked. Of course, the fact that others are doing it in contexts governed by very different ethos than the research context does not mean that we should do it the same way or to the same extent. So in these brief examples, I think I've sort of alluded to some of the pros of record linkage, or at least some laudable goals researchers might hope to accomplish by doing it. And we're going to hear more about pros and cons of record linkage in the next few talks and throughout the meeting. So here's my very, very partial list of why we might want to do it and what some of the benefits are. And first and foremost, I think because we might improve the quality of research by doing it for a variety of reasons I've listed here. But one point that may not have really been apparent in the examples that I gave is that record linkage might also decrease burden on research participants in some cases. So if researchers don't have to gather all of the relevant information by interacting with a participant, then surveys can be shorter, study visits might be shorter, or we might have fewer study visits. So these are just some benefits of record linkage. But as with any complex research activity, record linkage also raises concerns. And if it didn't, we probably wouldn't be having this meeting today. So I also have a very partial list of some of the concerns. So I think it shouldn't be lost on us that the purpose of linkage is to learn things we couldn't learn otherwise. And this might include information that people or communities don't even know about themselves and didn't agree to have studied. And so record linkage may raise concerns about loss of autonomy, dignity, or sovereignty. It may raise concerns about researchers' trustworthiness. Of course, privacy risks are widely recognized, including by the community of data scientists who work in this area. And I think most of the focus has been on individual privacy risks. Less attention has been paid to concerns that communities might have about being identified or stigmatized through the use of linked data. So that's something we might think about here. And finally, I raise the point of exploitation in part because in other contexts, researchers have shown, for instance, that consumers often feel exploited by the way that their daily activities on and offline are datified and commodified. And here I'm thinking particularly of the work of Joseph Turow and others at the Annenberg Public Policy Center at Penn. And they've done extensive national surveys on this topic. And they've shown that actually consumers don't think about their interactions with purchases on the internet as a trade-off between my privacy and some benefit. And they often feel instead that they don't have other options besides doing things that create data for somebody else, and they feel exploited by it. And so this brings me back to the point that biomedical researchers, our goals and guiding ethos should not be, of course, the same as those of commercial entities. We have or should have a different relationship to research participants and other people who contribute to the advancement of knowledge. So just because other types of entities use data in ways that make people feel exploited and disempowered, we, of course, don't have to do that and shouldn't do that. So I'd also like to just raise some general points to consider. This first one, I think, has been made or is at least implicit in my previous comments, right? That data linkage can combine data collected in very different settings and different contexts, including contexts where people never anticipated that the information generated would be used in research, and that raises a number of ethical and policy issues, as I just highlighted. I also think there's probably work to be done to understand when and how the different contexts in which linked records were generated should be taken into account in the analysis that is done after the linking. as we know from data science generally, the same piece of information can mean different things in different contexts. For instance, an ICD-10 code may be used differently in different healthcare organizations or by different types of providers. And that can be a problem whenever data are aggregated across health systems or provider types, even if the data aren't linked. So we should also probably be thinking about how different contexts in which data are generated about a single individual might affect the interpretation of linked data or even the value of doing particular kinds of linking. The next two items about federated or consolidated types of data and where you store the data, these are technical issues, but I think my point in just raising them is that depending on the choices one makes about whether to use a federated or consolidated system, whether to store in the cloud or store maybe a linked data set locally and then distribute it to users. So those choices are policy choices that have different implications for how we, of course, protect privacy and anonymity, but they also have different implications for thinking more generally about data governance and issues like indigenous data sovereignty. So I think those technical choices have broader policy implications than sometimes people have considered. Now, although record linkage has a long history and is widely used, it isn't always technically straightforward. And so I've been talking about record linkage as though it just happens, but of course there's a complex science involved in making it happen, and there will be some error rate. So there are two kinds of mistakes that can happen. One involves the possibility that records about a particular individual will be in more than one data set, but they don't get combined. So that's one kind of error. Another kind of error involves a situation where records about two different people are actually combined together and represented as pertaining to only one person. So those are the two types of mistakes. Of course, data scientists are developing methods to try and minimize and avoid these mistakes. And I would say there are two general ways of linking, one that involves using unique identifiers. And so that would be an example here from the Scottish healthcare system. But, and that decreases the possibility, if you truly have unique identifiers, of making a linking mistake, but it also raises other issues. There are more privacy concerns with this, and in the United States, if one has explicit unique identifiers, then one has to contend with the Privacy Act or possibly HIPAA, so you're more regulated in that space. And on the other hand, there are methods for linking records across data sets that don't rely on having unique identifiers, but those methods might be somewhat more error prone. And of course, again, data scientists are aware of this and working on this issue. And also, calling for standards for doing the linkages and for reporting how the linkages are done. So I just, I want people to be aware that data scientists are on top of this to some degree. I think where this is relevant for us is it might raise justice issues because to the extent that we're linking without explicit identifiers, we're using different features in the data set, and people who, we know, for instance, with health data sets, that people who are less well off, people who have lower quality insurance or no insurance, health insurance, have sparser data in health record data sets. And when they have sparser data, the likelihood that a linking mistake occurs with respect to them, I think, will be higher. So I just want to point out that even when we're talking about linking, it's entirely possible that mistakes are not random, that mistakes will happen to the people who are already sort of least well off in the system at a higher rate. And that brings me to the fact that we will spend a few hours tomorrow talking about ethical issues and ethical issues beyond the privacy issues, which of course have been very, very prominent in this space. I am not going to read the verbiage on this slide. Maybe I'll take a moment to let people just look at this slide a little bit. And I guess while we're thinking about ethical issues, one point I will make is that in my own admittedly not totally systematic attempt to search PubMed for ethics articles on record linkage, I found next to nothing that is specific to record linkage. So I think there is a lot of work to be done here. And for instance, when we're thinking about informed consent, not just thinking about, well, when do we need it and when do we not need it to do record linkage, but also what's going to count as being informed, how and when should informed consent be obtained, when it should be obtained, right? So we have quite a few questions that could be addressed in this area. With respect to privacy and anonymity, I want to say that that's going to be our topic for today. And we really have two issues here. One is the protection of privacy and anonymity during the process of linking records. And I think we're going to hear today about privacy preserving record linkage methods. Again, this is an area where there's a lot of ferment in the data science world and people are doing a lot of work on this. But once the linkage has been made, now you have higher dimensional data. You have more features about each individual. And that means that those data are perhaps more susceptible to re-identification attacks, or the storage or computation on those data is more likely to leak an identity in some way, right? So I think we really have kind of two levels of issues with respect to privacy and linked data. And then I just want to point out that, there's a lot of discussion about the technical ways in which we can protect privacy, that those methods might be in tension with the usefulness of the data. So you can do things like adding noise to data, but when you do that, at some point you decrease the utility of the data. So there are trade-offs there. I also want to say that tomorrow we'll be talking about more about engaging communities, and we'll be talking specifically about participant views tomorrow. But the interesting thing about data linkage is that it can engage many publics, and it certainly can engage each of us through different identities or facets of our lives that we often maybe keep separate in a social or psychological way. So because record linkage can involve all kinds of records, from administrative governmental records to administrative private records held in private hands, to to potentially records having to do with things like education and so forth. It can bring together aspects of our lives that we often think of as separate or want to keep separate potentially. So I think we actually might need some innovative ways to engage people in deliberation in ways that they can appreciate the way that record linkage can bring together different aspects of their lives and illuminate things about them that, as I said earlier, they might not even know about themselves. All right, so here's my last substantive slide before I introduce the next speakers, which is that, okay, we're all coming out of the pandemic. We hope we're coming out of the pandemic. So this is my on the one hand and on the other hand slide. And so I want to say that on the one hand, there are things that are ethically acceptable to do in the context of a pandemic that would not be acceptable to do otherwise. So more than 50 years ago, the philosopher Hans Jonas, when thinking about why is it ever ethically acceptable to do research involving human beings, incidentally had a very thoughtful analysis of how a public health emergency that actually threatens the fabric of society justifies certain actions in research and outside of research that would never otherwise be justifiable. And I think he was right about that. So on the one hand, there might have been things that we did in research because we were in a pandemic that we shouldn't do otherwise. And here's on the other hand, a lot of people got really creative and innovative in terms of research methods during the pandemic. And many of the things that people did are things that we probably want to continue doing after the pandemic. They're things that probably could contribute to better, more efficient, more participant-friendly research. And so, I'm sure I don't know the scope of things that people did in data science during the pandemic that they might not otherwise have done, but I suspect that might be part of our discussion here today. So with that, I am going to move forward and hand off to our next speakers. So first, we're going to hear from Dr. Alastair Thompson, Chief Information Officer from NHLBI, who will talk more about what is record linkage and maybe how it's done, and thinking about pros and cons of record linkage. Then we'll hear from Dr. Sam Michael, the Chief Information Officer from the National Center for Advancing Translational Sciences. And Dr. Michael is going to he's going to provide us with a use case and talk about balancing pros and cons in the context of a particular use case. And finally, we'll hear from Dr. Lynn Penberthy, who's Associate Director for the Surveillance Research Program at the National Cancer Institute. And Dr. Penberthy is going to give us a landscape analysis. And so I think we'll find out more about, in particular, what NIH is doing with respect to record linkage. So with that, I would like to hand off to Dr. Thompson.
Thank you, Dr. Osorio. Hi, I'm Alastair Thompson. I'm the Chief Information Officer at NHLBI. I also serve as the co-lead for the NHLBI's Biodata Catalyst program, where we have gathered together a large amount of data from NHLBI-funded cohort studies, and where record linkage could demonstrate some significant value. Next slide, please. So what is record linkage fundamentally? And it allows us to identify records across data sets and across time that are associated with the same individual. As Dr. Osorio said, it's a long-standing practice. The US Census links data across survey sets, the CDC, with NHANES and others. And why is this actually important to us in the biomedical world? So some concrete examples of ways that we're thinking about or are actually using record linkage include deduplication of data which come from multiple sources. For instance, we have multiple studies in MISC where we've got overlapping patient enrollments, but we don't necessarily know that they're overlapping. And it's enabling us to disambiguate an individual across those studies. There's also potential for the linkage across data repositories. For example, linking electronic health records, such as captured by N3C, and stored separately from imaging data that's also maybe captured separately to be able to bring a complete view of a particular patient together. We can link EHR data across providers and across time, so across health systems, and get to a better view of the history of a particular patient. One particular area where we're beginning experimentation is linking participants in clinical trials or observational studies with their EHR data. For instance, the ORCID trial, which was hydroxychloroquine versus placebo in acute COVID patients. We're working to link those trial participants to the N3C's EHR data, which will enable us to ask questions like, between patients that receive hydroxychloroquine versus those that did not during their acute hospitalization, what's the frequency of subsequent medical encounters? What was the result of it? Did it cause any long-term impacts? Obviously becoming a real question for us in terms of long COVID and all of the implications and sequelae of COVID. Next slide, please. So the linkage process is simple yet complex. Taking data from two databases, you pre-process it, clean it, do whatever you need to do to make it valuable. Then you index it in some way. That can be done in a variety of ways, which I'll touch on, with varying levels of rigor, fuzziness, and other things. Then you compare them and you make a determination and classification as to whether or not an individual across a record across the two databases are for the same individual. That may be a simple match. It may be that we know that it doesn't match. But in many cases, because this is not a direct deterministic question, there may be possible matches. And so those need some level of human review, which can be fairly extensive. And then even at the end, you've got to evaluate the results and see how they're doing. Next slide. In terms of the comparison methods, there are some obvious ones. For instance, assembling an identifiable data like first name, last name, date of birth, and sex, and comparing and using simple string matching, which obviously is very intolerant of errors, typos, misspelling of names. You can improve it using techniques such as SoundX to look at the phonetics, but it's still not particularly good. You can get further improvement from comparison functions that measure similarity in some way and enable a more fuzzy kind of match. The Hamming method and the Levenstein distance are two methods that use the structure and counts of characters in a string like the first, last, date of birth, and sex to make a determination of a measure of similarity. And then by some criteria, you make a determination that they're similar enough to be regarded as the same individual. Next slide, please. Those are obviously all very well, but they require access to PII. And so enter privacy-preserving comparison methods. The basic goal of this is to transform the PII in a way that's not readily reversible. So if you have the transformed data, you can't transform it back easily. But it's also got to be able to be matchable using the transformed data. It's no good if you transform it and it loses the ability to match with other things. And we also want to be able to retain the ability to do fuzzy matching because of the spelling errors and other variations. So some of the common methods for this are things like hashing, where an identifiable string is hashed with a hash algorithm from cryptography, such as SHA-256, to generate a string of random numbers. Hashing is easy to do to get the hash. It's extraordinarily difficult to do to reverse it. It requires brute force, and with modern algorithms, there's no reasonable way that you can do it. You can also use reference values of some of these methods like Levenstein relative to agreed upon identifiers. So you measure the difference between agreed identifiers, and then if the reference values are similar, then you can say that the original data was similar without actually having to see what the data is. You can use distances between records by some measure of distance and transforming them from one space to another. More techniques are starting to be evolved for securing multi-party, like homomorphic transformation, where the data can be transformed but has the same statistical characteristics as the untransformed data and can be used that way. These all have a variable risk of privacy being broken. Some are invulnerable to brute force attack, but the risk is somewhat dependent on the level of similarity matching available. The more secure it is, the more computationally complex it is, and the less you're going to be able to get fuzzy matches and other things. Next slide. A lot of this comes down to value versus the cost. And when I say cost, I don't just mean cost in dollars. I mean cost in potential risk to privacy, cost in other factors as well. But privacy-preserving record linkage opens up ability to integrate that data from multiple sources across time and identify duplicate participants. It comes at some risk to privacy, depending on the method used, and it tends to be related to the ease and quality of matching. Multiple layers of protection can help, for instance, combining hashing with encryption to make it more difficult to extract original data. But technology is not the only part of the solution. PPRL needs trust beyond just the technology. And I think we sometimes forget and get too excited about the technology and forget that this is data from people, real people. I think Dr. Osorio made this point very, very clearly, that we need to deal with the human factors in this as well. And so how do we engender trust? And so there are uses of independent, honest brokers so that groups never have the actual PII themselves, and it's just the honest broker, so the trust is in an independent group rather than perhaps the NIH, and various other methods. Next slide, please. Fundamentally, PPRL is a trade-off. The scientific value we get for it varies based on the quality of matching, and particularly in terms of potential bias. And I'll mention that again in a minute. Computational complexity. The more secure it is, the more computationally complex it is, which makes it harder and more expensive to do it. And then there's the risk of privacy breach. And finding the happy medium in this is going to vary very much based on the individual population, the culture they come from, and a variety of other factors. Next slide, please. One of the areas in particular that we're concerned about is risks of introducing bias into research. We've all become hyper aware of health disparities thanks to COVID. We've got to be very aware that using record linkage in the wrong way and not without due thought can actually introduce bias that can exacerbate these disparities. And it can do this by reducing match quality, where that match quality is aligned with demographic differences. So for instance, name changes through a lifespan will reduce the ability to match. The given and family name ordering variations between cultures. The use of phonetic and transliteral name spellings, which produce higher levels of spelling errors in electronic health records, for instance. And as Dr. Osorio said, the sparseness of some data for a whole variety of reasons, whether it's availability of insurance or data sets from indigenous peoples where there is not a high level of trust, and so they're not made available. And that can lead directly to reduced participation in research by those impacted groups, who are often the groups we most need in the research. And so we've got to be very thoughtful about how we use this, and we need to be very cognizant that we need to actually take active steps to limit the effect of bias, and at least to assess the biases that are there so that we know empirically what's happening. With that, I will turn over to Dr. Michael.
Thank you so much for the introduction, Alistair, and also Dr. Osorio for, I think, really the heart of a lot of this. You know, this is going to talk about an implementation that was actually done regarding PPRL with the N3C. And there's a lot of, obviously, the technical what we can achieve, you know, and how we do it. But then, you know, the question, the proverbial should we? And I think this is an area where the technical folks really need the guidance from both the ethicists and the policy professionals to really help us in this case. So Alistair mentioned this prior. This use case is going to focus around what we're doing with N3C. So this is a collaborative analytics platform, and Dr. Osorio also referenced this, you know, the difference between sort of federated or centralized. In this case, this is a centralized enclave consisting of millions of electronic health records, which have been collected during the course of this pandemic, with clearly, you know, one of the biggest points about this, or the biggest priorities, making sure that this is secure and also privacy preserving, a huge aspect of this. To date, just for a scope perspective, we have over 6 million total patients, with over 2 million of those being COVID positive. And all of this data has been submitted by sites. Actually, this was as of the 21st. Now we're up to 57 sites, all of which have to sign a data transfer agreement to willingly allow their data to be used, which is a limited data set, meaning that we actually have a 5-digit zip and the date that a procedure took place. And so this is showing that we have a massive scale of electronic health records, but how can we actually make a richer data set potentially for research use by including other data types? And in this case, in the example we're going to show, is going to be with imaging. And before we get there, though, this gets back to the oversight question, and you know, people can't just come into the enclave and start linking data. And I think everyone would make that assumption. There's an extreme amount of oversight that we put into place. One, first and foremost, by having different data classifications, essentially linkages of use of data not involving individual persons, all the way to linkages using hash identifiers managed by a third party honest broker to connect multiple enclaves. And with this, we need a data use agreement, data access committee, letter determination, and now we're coming up with, we're calling a linkage honest broker agreement, which is essentially another agreement that the people providing the data have to allow to even be linked. And so I just want to make it very clear, we're trying to put many controls in place for all of the concerns that Alistair and Dr. Osorio raised about that preservation of privacy, autonomy, and making sure that this research is done ethically. And so I want to talk about some of the pieces of this implementation just so people can get their bearing. And so we have the N3C data enclave that you can see here. And within that enclave is a user, someone who's registered for access, and a researcher has their own private workspace. We also have the linkage data broker themselves. In our use case, for our example, we're using Regenstrief Institute, and to the point Alistair made about the tokens being generated, which also include encryption, are being generated by Datavant. And so I just want to get their bearings as we have the linkage data broker, and then we have the contributing sites. And so the sites they tokenize their data, and those tokens are sent to the linkage data broker. And in the case of TCIA, the Cancer Imaging Archive, who has the images, they have tokenized their images as well. Want to stress the data itself never goes to the linkage data broker, right? So the contributing sites, they have sent already, their electronic health records exist within N3C. The tokens are what are sent to the linkage data broker. And so the user wants to submit a request, and they want to provide a linkage. And so in this case, the example we're showing is we have a research project, and then our patient cohort are COVID positive, and we want to link actually imaging from the source, in this case, TCIA, the Cancer Imaging Archive, and they're going to submit this request. And what happens when they submit this request? And I want to walk through this here. So the green is the private workspace in the N3C data enclave, and they specify through the form the actual cohort that they want. The purple in this case, this is behind the scenes. This is sort of the guts of what I would say is our cloud-based platform. And so they submit the request. That request goes to the linkage onage broker, and then the record linkage process that Alistair referred to is what happens to come up with the TCIA match file. That file is then sent back to the N3C enclave, at which point it recognizes that based upon the matches that were found, it needs to get the appropriate electronic health records, but it also has to make a call to the Cancer Imaging Archive to say, I need to get the appropriate images from you to bring into the enclave. Once those images from TCIA are actually into the overall environment, a private workspace is what has the combined electronic health records and the images in one environment that's suitable for computation. And so from that simple diagram I showed earlier, what I want to show is a little bit more complex that just kind of walks through with more details the process we went through. The real point I want to make of this is just to drive the point home that the images from TCIA, which have no identifiable information, that's a direct connection, and those images are sent to the N3C data enclave. And this is just to make sure we're clear that the linkage data broker never receives data of any kind. And the other part I want to drive home about this and the workflow we just showed, this is operational and we can perform this today. This is an example showing, and later on in another meeting that we're going to have, I believe a couple of months from now as part of the NIH Jumpstart initiative, we're going to show in deeper detail this particular use case. But I do want to talk a little bit about, what this means or what this looks like once we bring these images in, because I think it's important that this is what we talk about this is patients, right? We're looking at this is binary data, this is DICOM images. And once we bring it into an analytical environment is we can perform image analysis. And so a data researcher, a data scientist is going to, start getting busy and doing work with different techniques for image processing algorithms and maybe doing thresholding, machine learning, deep learning. But again, we have to be cognizant, as Alistair said, that this is patients, right? We are looking at someone's chest cavity here. And again, in this particular instance, we actually found 16 patients, and that corresponds to 3,200 matching images because we took these over time. And we were able to perform a project that, based upon the image analysis, we could actually correlate that with saturated O2 levels decreasing and actually also a drop in creatinine levels, which there's a lot of publications have come out during COVID about this result. But, this is just showing, again, this is as personal as it gets. If you look at these images, I'm not a radiologist, but these lungs don't look that good. And we can actually match that up and see that there's a huge drop in saturated O2. I don't think this patient had a good outcome. And so part of the reason I'm very interested in participating in this work group, and again, to get all the policy and ethical perspective, is we're dealing with incredibly sensitive data, and we want to make sure that we protect the patient's privacy, but also their integrity. I think that Dr. Osorio raised that point right from the start. And so these are very profound questions, I believe, that we're asking here, with all the complexity of the technical implementation aside. I mean, this is an interesting one that 16 patients have 3,200 corresponding images. Imagine if we have this for, 1,600 patients or 16,000 patients. The technical complexity becomes immense. And also, Alistair alluded to the computational cost. And so there's a lot of variables that we have to weigh. And so really, I just want to show this particular implementation at a very high level, let everyone know that it's actually working, but then happy to participate in the rest of this seminar today. And with that, I'll hand it over to Lynn.
Thanks, Sam. Right. So while I am going to talk a bit about a landscape analysis, we also are doing a formalized evaluation of privacy-preserving patient record linkage software. And this came about really because P3RL is of great interest, as you all know already from this conversation, because we have a pressing need to connect patient-level data across multiple and different data sources, data types, and research studies without release of PII from the original data owners or PII data holders. There's interest across the NIH, NCC, and CATS, and of course, NCI as well. And there's been no formal evaluation of the more than 50 vendors who say that they can do this P3RL type of linkage. And so there are a number of challenges that were already mentioned, but I thought it was worth discussing those just briefly. Of course, the first and foremost is protecting patient confidentiality and privacy. We also have to think about consistency of PII across these diverse data sources. Oftentimes, there are very different PII levels. The other thing that's important is that PII can evolve over time, as was mentioned earlier, not just with name changes, but also with residential history. People move. Our population is very migratory, and so being able to have that residential history may be very important. And of course, the accuracy of the linkage that we get is going to vary according to the accuracy and completeness of the PII that's available in the data sources that are being linked. And then lastly, the scalability of whatever system we choose to use. So the NCI, under the Cancer Moonshot funding for the cancer data ecosystem, supported a two-phase study on software applications that supported P3RL. The first phase of these was to evaluate the landscape of multiple vendors for privacy-preserving linkages. And a formal assessment was done by a contractor using website review, white paper reviews, summarization, sometimes contacting the vendors, and then a survey of vendors. The assessment resulted in a formal report that included 52 vendors that were identified in the marketplace. And of those, 8 appeared to meet P3RL requirements for this project and were then further surveyed or spoken with as needed via telephone interviews. Of the eight that were interviewed, I should say, 4 of these were determined through objective scoring on the survey to be appropriate for more formal evaluation against a set of gold standard data. And these 4 included Datavant, Healthverity, Senzing, and Crossix. So this is just a summary of the process that we used for the initial landscape analysis. We had stakeholder, which was largely NCI, and subject matter expert input with some of the folks on this call today, in fact, with a literature review and working with Leidos National Lab and NCI. We captured the requirements that were needed for this landscape review. The contractor identified candidate software applications. We meanwhile developed evaluation criteria, and then the software were evaluated with recommendations and next steps. The evaluation criteria included 6 different categories of requirements: functional suitability, performance, interoperability, usability, of course, reliability, and that is how good was the support for this, security, and then within those there were multiple subcategories within the main categories that were also evaluated. So this is an example of the scoring criteria that we used along with the weighting for different facets of the evaluation. So as you can see in the table in the upper left, the question and response was scored from 0 to 3. And then there was some weighting that we used, and this is an example of weighting for a few of the categories. And as you can see, not unexpectedly, we highly weighted the PPID generation and record linkage process as the most important factor for the evaluation. So what we also had done for this is really the phase 2, which is the formal evaluation of those 4 vendors that were identified as potentially being eligible to be further used for privacy-preserving linkages. And so data sets with PII were used to generate a gold standard, that is, with identifiable linkages. The gold standard was created through linkage performed using the MatchPro software, which is a software system that was developed by one of our contractors and used routinely by cancer registries and others for linkage using PII. Questionable matches through MatchPro were validated manually, and if necessary, were actually sent to the registry data owners for further review and confirmation. So once we had these, there were 3 use cases that were identified. The first of these was linking 6 SEER registries together. And this was, we thought, useful because they have excellent PII, and including SSN. The second use case was a large SEER registry that linked with pharmacy claims data from CVS, Walgreens, and Rite Aid from 2013 to 2017. And we thought this was good because the pharmacy data had slightly less robust PII. There was no SSN. And there was also a differential residential history that we felt was a necessary part of this analysis. And we actually added residential history through another source to assess the ability of the software applications to link longitudinally and across multiple addresses. The third use case was a perturbation of use case 2 of the PII, which we felt mimicked real-world data where there could be errors in how the data was recorded. The formal criteria that we used for phase 2 included things like false positive, false negative, precision, recall or sensitivity, specificity, and F measure. And I won't read all these because I suspect that most of you are familiar with these. But we also had some informal criteria. And those included things like ease of use. How easy was it to install the software and use it? What was the flexibility for the linkage process? So was there an ability to customize or vary tokens, that is, combinations of PII that got hashed? Was there the ability to add other confirmatory variables that were not necessarily PII? And perhaps most importantly, for some of our applications, was there the potential to select or modify levels of false positive or false negative for the matches? As was mentioned earlier, for many of us, the false positive rate is probably the most concerning, so we wanted to minimize that. We also looked at things like process speed, scalability, and runtime, vendor support, and then the breadth of the use cases that were supported. This is really quite informal, but I think we're working on how to capture that in our report. So the lessons that we learned from this is that when you perform a linkage using these hash tokens, you really need to understand the methods that are used by the vendor. And I think this is alluded to earlier. So are they probabilistic, deterministic? Is there a combination of the two? Do they use modeling as part of that linkage process? Also, I think it's important to understand the primary function or mission of the vendor who's created the software. So is the vendor specifically developed for P3RL and linkages, or is the vendor leveraging the linkage process for internal data aggregation? And there are a number of software applications out there that do that. Is the accuracy potentially impacted by years of data that are included? And one of the things that we found initially is that the older data really is less accurate for some of the vendors in terms of the ability to link. And then lastly, is there ability for partial customization of the matching process? We felt that that might be very, very important in certain applications to achieve a high level of accuracy. If possible, we felt that it was very important to be able to sort of train or test the linkage algorithm for your specific data. That is, can you take a small subset of the data and use that as a gold standard to verify or validate the linkage process that you're using? Again, the use of P3RL may be dependent on the use case that you are contemplating. So what is the completeness of the PII and the two data sources that you're putting together? What are the types of PII available? So do you have social security number, which is really a win, but most people don't have that. Do you have complete name, date of birth, address, other characteristics that might be included in PII. So all of those are very important considerations. Another thing that we really looked at is the flexibility of the vendor software. Is there the ability to potentially vary those tokens and token combinations? Because that makes a huge difference in the accuracy of the outcomes. Is there the potential to add relevant variables for verification of specific use cases? And the example that I'll just mention here is that for linkages across the registries, adding a cancer ICD for linkage with cancer or other specific disease ICDs might help to improve the accuracy of these encrypted linkages. And then even with high quality PII, the logic and methodology will still be optimized by some tailoring and testing to domain specific data. So in other words, I think this P3RL is just not one and done. I think it's a very complex process and really needs to be thought through very carefully. So the next steps that we're doing in our formalized analysis is to finalize the results and report for Datavant and HealthVerity, who are the first two vendors that we've analyzed, and we're very nearly completed with that. Also to complete the assessment for Sensing and Crossix software, and then to develop a report for those two. And then what was very interesting that came out of this is that we felt that it was worthwhile for us to develop a specialized P3RL process as a module for Match Pro, the software that I mentioned that we used for the initial linkage for the gold standard data creation. And the reason that we felt that that was worthwhile is that we identified some special use cases for institutions such as cancer registries that may have very high quality PII and that have a real necessity for minimizing false positive matches, and that also may have the potential for pre-testing and manual adjudication post-match. That is, the data owner holds and maintains the encrypted tokens so that they can validate some of the data to assure that there is an appropriate level of accuracy for that linkage. And with that, I thank you, and I'd like to thank my collaborators, specifically Will Howe from IMS, who has done a lot of the work in evaluating the software system.
All right. Thank you all for those really wonderful and on-time presentations. So we have time for some Q&A. We have questions in the Q&A. And so perhaps we have, and some questions have been answered in the Q&A, but since everybody might not have been reading that, I personally find it hard to go back and forth between chats and Q&A and listening to the speaker. So perhaps we'll start with data use agreements. So this is a question that maybe Sam and Alistair can answer. Somebody asked whether there are different types of DUA options for different types, or different DUA options for different types of data sets that might be used.
Great. I can say specific to N3C, we try to make it, just given the sheer volume of agreements that we have, which is in the hundreds, we intentionally wanted to make sure we had a universal data use agreements. That being said, for other environments, there's nothing stopping a different governance group from saying that they might want to have some specificity or some individuality to the different data use agreements they want to put in place. It's a really great question. A lot of this does come to, I would say, the dreaded G word, which is governance, right? You know, in terms of all of these enclaves and you know, how people are handling these environments, how they actually want to govern their use.
So I think that's a really great question. And one of the things that I have learned from multiple experts with whom we've consulted for much of our data, which is largely registry data, is that you can do the maximum to protect patient privacy and confidentiality, but that it's really always good to have a data use agreement that really specifies how the data can be used and what the limitations are, because I think that's important to confirm with the end user and to have that additional agreement, because there is no perfect system for de-identification. And particularly as you get more and more complicated data longitudinally on each patient, there is a significant risk of re-identifiability. And so that data use agreement, I think, is absolutely essential for part of this.
And presumably these data use agreements include the point that people won't try and individually re-identify. What about at sort of use of data to identify communities? I mean, in some cases, that seems like it could be a goal, right? Particularly with epidemiological research or something like that. And And at the same time, some communities could have sensitivities and not want to be singled out. Okay. All right, let's go on to a different question. And again, this one Alistair answered in the Q&A, but just to have it aired, and if other people want to answer it as well. And this is a question about the fact that there are many different methods, as Lynn has pointed out, for record linkage, and that different ICs have been using different methods. So is NIH planning to consolidate or develop some standard approach or a couple of approaches or methods for anonymizing data and doing record linkage? So perhaps Lynn and Alistair can go with that.
Yeah, I think at some point we are going to have to settle on some small subset of standards to be used to enable interoperability. We're at a very experimental stage now with this, and there'll be multiple pilots. But I will also note that PPRL shouldn't probably be used alone, that it should be used in combination with globally unique identifiers, so that once a linkage is made, a GUID is assigned, and so that you're not going back to have to go and do linkage and other things. And so long as we have a central repository of GUIDs, we'll always be able to link regardless of what the technology is, particularly as the technology evolves, as I expect it to.
I think that's a great point, Alistair. And so one of the goals behind the NCI funding this evaluation landscape analysis was to identify one or more of these systems that could potentially be licensed or used by NCI for various linkages. And so I don't think there's any single entity that works really well. And I would agree with you that, in fact, having that unique identifier as part of this is really helpful for the many federated systems that we have, at least in NCI, and are continuing to develop.
I feel like I didn't give a sort of definition of a federated system, but for some people in this meeting, it might be useful to explain how federated systems work. Would someone like to do that?
So I'm not really the person to do that, but since Alistair and Sam aren't speaking up, I'll give it my best shot. So just from a pragmatic perspective, we do this with the cancer research data ecosystem. So the TCIA versus some of the GDC versus the SEER data are sort of independent systems. And where we're trying to go with this, we haven't done a great job to date, but where we are trying to go with this is to provide the opportunity for investigators as appropriate to be able to combine these data sources, even though they are independent, they're not necessarily linked and combined sort of in reality, but in a sort of a virtual way. I don't know, Alistair or Sam, give.
Yeah, no, I think you're saying that very well, and it becomes a technical challenge, but it's imminently doable, and actually part of the work that's ongoing that NIH is looking at this post-acute sequelae of COVID as this concept, essentially this ephemeral workbench, they're calling this, where it combines data from different environments into one computational space. And I think, Dr. Osorio, you raised the point though, okay, what happens to the data? Is it cloud? Is it distributable? But no, absolutely. I think, Lynn, you're describing that well, because this is a challenge that all of NIH is facing, right? We funded for years millions of dollars worth of different data repositories that are all set up to do their own thing. And how do we potentially combine those? So I think the question is definitely one of technical and security. One thing that Dr. Gregorek has really got many of us excited about as a concept, as dry as it may sound, is a sort of a bundled security agreement, interconnect, connection security agreement, because you have to have these agreements in place between the different environments before you can figure out where this landing pad will be essentially for the research to take place. But there's a lot of work going on in this space at NIH, and every technical implementation is a little bit different.
I think it's worth noting that even if you can link the data, it may not be that useful to you. Data still needs to be harmonized. All of the hard work that we do whenever we look at data it has to be done. You can technically do it, you can put it into an ephemeral workspace, but if no one is looking at the data and making sure that it is aligned with measures and CDEs and everything else, then it can lead you astray.
I would just like to comment on the last, there's a comment in the chat that I think it's really very relevant that the linkage needs to include an adjudication process. And that's sort of, I think we were all alluding to that, you know, depending on what you're doing, you know, probability versus deterministic, can you do that validation of a small sample? It's incredibly important because you can't just assume that just because something gets linked, that it's correct. And that was my take-home message from all the work that we've done in this project. So I think it's very, very important to consider that.
Yeah, and I mean, to me, this is always interesting, which is watching the scientific community begin to sort of develop certain kinds of governance from the ground up, right? And so this is the beginning of, we need some standards, we need some agreements, adjudication processes. Yeah. Great, thank you all. So we will reconvene at in 10 minutes who is the program director for the Outcomes Research and Biomedical Informatics program at North Shore University Health System, which is associated, I believe, with the University of Chicago. So he is going to give us a 10-minute sort of introduction to some privacy issues related to record linkage.
So thanks, Pilar. I guess this is a fairly personal presentation. You know, from my own experience with privacy preserving record linkage and the work that we've been able to do, I give credit to my colleagues in 2 working groups in EMEA, but especially to my colleagues in the Capricorn PicoNet network and AbleCo in particular. So what I'm going to cover is something about the technology, records and identifiers, encryption, hashing, and so on. Much of this has already been said, so it's going to be more in by way of review. And then I'll talk about a few of the ethical and the critically ethical issues that have come to my attention. And as I said, this is a personal presentation. If you think of a database as a large table of data and each row representing, say, one patient, we tend to think of the identifier in that row as the key, the medical record number, the MRN, something like that. But people who work with databases know very well that other combinations of fields in the table could also identify a patient. And you know, the language in database theory is that these are candidate keys. And one of the worries we have in our field is to eliminate candidate keys from any data that we release. And as we all know, there are 2 ways of doing it. Safe harbor, whereby we remove 18 specific identifiers. Actually, the 18th is any other identifier that may identify a patient uniquely. Or the alternative is expert determination. And expert determination requires someone to certify that the probability of re-identification is negligible. There are 2 things to be said about that, is that there are very few people who can do this, and that the cost of doing so effectively can be quite prohibitive. We've already heard about hashing and encryption, and just a historical reference is that hashing was originally invented to enable the storage of passwords. If you storage the passwords in clear, you know, obviously they will be insecure, because anybody who manages to break into the file will see everybody's password. So what do? You introduce a one-way irreversible process which takes the password and creates a code which can be stored in the clear, because it is impossible, or more or less impossible, to reverse the process. And it is known that this approach is vulnerable to a so-called dictionary attack, and whereby you take, say, the entire electoral register and put it through the same process. And if you get some collision, some hits, then you are beginning to re-identify people. And there is a philosophy of open security, and in opposition to security through obscurity is rather nicely put by a man called Hobbes in 1851. He was a locksmith, and he was rather given to showing people how to pick the latest locks in his time. And people used to, accuse him of being irresponsible. And his response to this was that rogues are very keen in their profession and know already much more than we can teach them. And this really, in a sense, goes through today as well. And Peter Swire in 2004 wrote a very nice paper analyzing very extensively the pros and cons of the military attitude, which is loose lips sink ships, with the concept, the engineering concept that there is no security through obscurity. Now, I think Pilar has already pointed out that the more data is out there, the higher the risk, is the greater the dimensionality. The sources of complementary data cannot be controlled. And bear in mind that in some cases of re-identification, the complementary data was simply newspaper pieces about accidents that had happened. And so the quality of the identification must be controlled, otherwise it really poses a serious risk. There was a particularly bad case in Australia. Privacy preserving record linkage, again, it's been described. I'll just cover it very, very quickly. The combinations of identifying data from institutions are put together in different sequences and different combinations. A secure salt, as it's described, a random number is added to them. They're hashed, and the hashes can be shared with an honest broker. The honest broker, again, as has been pointed out, does not see any data, but can provide a single minted ID for each patient. In other words, not a computed one, but something that is randomly assigned. And here's an example from a paper that started all this for me, a paper by Abel on a privacy-preserving approach that we have introduced in the Capricorn CDRN. You can see the combinations that are used, and if these are taken from different institutions and they hash to the same values, there is a very, very high statistical probability that they are referring to the same person. We deployed this in a very interesting local project on homelessness. Now, this I offer this as an interesting contrast and counterpoint to the very large-scale record linkage with the N3C. This is a fairly small group. We're talking about a few thousand people, but homelessness is a serious problem in Chicago. And it did support policy to have shown that the degree of homelessness, whether they were in stable plus unstable, or totally unstable accommodation, correlated to their health, and in particular to their mental health. This required a lot of goodwill on the part of people maintaining a charity database, as well as the Capricorn CDRN database. And I pay tribute to Bill Trick for bringing all this together. So what's the right thing to do? Well, if you ask people about who owns PHI, who owns medical records, you get very, very adamantly two different answers, either the patient or the provider. And there is very little space between those two. The positions are taken as absolute. I think that this is something that needs to be addressed. From the point of view of data sharing and record linkage, the question of consent is also what data are we speaking of bringing together? Data from a trial often comes from patients from subjects who have been consented, and the consent may have extended to the use of data. But what about observational data, data taken from day-to-day healthcare? And the risks to this, I've already mentioned. Dictionary attacks are one form. The other is the degree to which data information exists in other public data sets. And for some communities, in particular Indian American and other native communities, this can be a very sore point indeed. This is a quote from an article in Vice with a quote from Joe Iracheta, who is a geneticist traces his lineage from two native tribes. And he puts it very clearly, it's all very well, you can say that this is progress, but who is gaining from this progress? And, Aileen Nielsen, who has done a more academic piece of work on this, and I give the references at the end, she used behavioral economic methods to see to what extent people are willing to share their data, at what price, and what conditions would satisfy them. And she points out that a high percentage refused to even name a price. And those who did name a price, the price was an order of magnitude higher than the market price. So there is clearly opposition out there among lay people to the kind of sharing that is going on currently, by Google and others. So there is an onus on us to avoid being painted with the same brush and to do this in a more responsible and more considerate way, considerate of patients' privacy and of their sense of their self-worth. I'd be happy to circulate these slides at the end, so you don't need to try and read the references right now. But there is a lot of work going on right in this area. And that is the end of my 10 minutes.
Thank you so much, Tony. Now, I think we are going into breakout groups.
Why don't I go ahead, Tony? I think the format was that each of the moderators were going to provide just 2 to 3 minute high level.
Oh, right. Yeah, Richard, of course. Sorry, I just realized this was your group. Go ahead. Yeah.
No problem. So like your group, we also had a lively discussion, and just a reassurance to the group too. I envision that we'll be able to circle back to a lot of threads that were only partially discussed during the course of our first conversation. For the larger group, I would say that our conversation focused largely around the first of the topics, and specifically around the topic of transparency and its role in terms of privacy and security. That transparency we talked about in a couple different ways, but it would be transparency of the release of health records to various kinds of entities, and sort of making clear to individual patients who is authorizing that release of health-related data. Additionally, transparency with regard to the potential uses of those records by the receiver of the information, and also transparency about the uses, the appropriate uses or unacceptable uses of data that's shared. Secondly, we talked a lot about the concept of data provenance. And here, I think this was a concept that was perhaps a little bit different from the ways in which these topics were talked about in some of the formal presentations. The idea is that without an ability to be able to go back and retrospectively assess the sources of data, who released those data and to whom, we would never have a robust system of accountability that would stand up to closer scrutiny by patients and others. We need to be in a position where we can say to patients, your data was released to this particular entity on this particular date for this particular purpose. And we talked quite a bit about the ways in which that kind of data provenance was important, not just in terms of governance, but also for the promotion of trust, that ultimately having that level of detail and an ability to reconstruct the distribution of data was critical for promoting trust. So I'll stop there. Anyone from our group like to add anything that I missed?
Sounds like you got it just right. Thank you. So this is the second group is the one that I moderated. We had an extremely lively discussion, and I'm really grateful to Nick and our note taker for managing to make some order out of the discussion. We had a significant discussion on the who, what, and how, not necessarily in that order, but who would get their hands on this data, what would they do with it, how would they do what they might do. This exercised us quite a lot. At the same time, we had two experts in Native American populations, and we had an extremely interesting conversation about the special conditions of special populations. And we were able to extend what we had already heard and discussed about Native American populations to other populations that have historically been disadvantaged. And the final point is that the way data is coded and the risks that may subject them to is something that needs to be paid attention to. And in particular, going back to the discussion of special populations, it can render them very vulnerable to particular threats if coded in a certain way. I think, I invite my colleagues to supplement that. And next we move to Sharon.
Okay, quite a lot to cover here. We had an excellent discussion that I think probably largely rests on the premise that if we're going to be talking about participants and research, that shifting toward participants being the origin and drivers of that research is a huge lift, but one that must be essential. We believe that in this group that the idea of chasing privacy will be quite difficult, and that the conflation of privacy and security sometimes is also making things more difficult. That the idea around inclusivity is not the same as exclusivity or even as a kind of equity in the data, and that we need to actually ensure that as well. Overall, we talked about the fact that talking about trust puts the burden on the participants, and that trustworthiness is really more of what we're trying to look at. We looked at the difference between consent and non-consent systems, because consent requires a level of literacy. Again, it requires that the community or assumes that the community didn't give rise to whatever is being studied. And so instead of thinking about this as a top-down, thinking about it more as a grassroots way to work together. Trust agreements need clarification, especially when data is what they call secondarily used, and even that seems to be contrary to some of the respect for the communities that we're talking about. How the data can be presented without being the community itself being stigmatized, and particularly in communities that are underserved and marginalized and don't have power in the systems that we're talking about here, also is critical. There are IRB concerns, repositories, enclave concerns, things about transparency and disclosure are difficult, particularly with the fluidity of cloud data, and that there needs to be this comprehensive sense of data, whether it's genomic data, social determinants, et cetera, but giving participants a sense of where their data is and how it's being used is critical. Again, back essentially wrapping back around to the fact that the people themselves for whom the benefits should accrue should be largely the ones who make a lot of these decisions, and that in the current systems that we have, that is just not the case. I'll stop there since I'm even over 2 minutes and see if there's anything I left out that any of the panelists want to include either in the chat or aloud.
Great, thanks. So we had a very lively discussion, a lot of which focused on consent, and we definitely got to the point that somebody raised in the chat, which is that actually the data linkages that are happening now, more of them are happening with completely non-consented people who probably in many cases have no idea that their data are being linked to create research resources. And so one of our points there was that governance is even more important in these situations, because people can't make choices to protect themselves in any way if they've had no notice and they've had no opportunity to consent or opt in. And, which is why we felt like partly that this debate was, we did spend a long time talking about the nature of informed consent and what it should look like and how it could even be done. But we thought it's in part relevant to this conversation because of, the extra need for governance if people aren't consented. We talked a little bit about the processes of notice that you might do in situations where people are not likely to be consented. We also talked about the possibility of notice and opt out and how feasible that is currently. We also talked about some processes of like who is doing things well. And one of our participants brought up that all of us spent a lot of money and a lot of time trying to develop data security and processes of data access that, may be exportable in some ways or generalizable. And so there are processes of sort of graduated permissions to get more and deeper kinds of data and more individualized kinds of data. And the rule that when one uses data, one does so essentially in public when one is using the all of us data. So people saw those two things as perhaps best practices in terms of thinking about privacy and security, and particularly privacy as not an all or nothing kind of thing. So we talked about it as contextual. And the last thing I guess I'll bring up is that we talked about how linkages that don't work or don't happen, or when people are missing data that that missing data prevents linkage, that actually can provide a lot of insight, and some of that insight might come with various kinds of risks. So one example we got was that if one is matching across health records using social security numbers, and one finds that, many people in a certain system or across a couple of systems are sharing the same social security number, then that might be a situation where you've identified a population of undocumented people who are using a social security number. And so even when there's missing data or the linkage doesn't work, that can create information, and that information can have risks. And I think I will stop there and invite members of our group to add anything that they'd like.
Thanks, Pilar. Your summary was as good as your introduction. This is great. Thank you so much. So I think we're essentially at the conclusion of this part of the day, and I believe if Patty's ready, yes, I'm handing over to Patty to close us for today.
Thank you so much, Tony. Patty had to step away, so I am going to share my screen. If you don't mind, Deloitte, and letting me do that, thanks. And her and I have been sending notes back and forth, so I'm going to share what we've come up with thus far. And this has been such a great day. The discussions have been really, really fantastic and quite informative. We understand that, you know, in creating record linkage, it's really about creating and enriching a picture of a person and their data through time and through many different ways that they've contributed data and information through different systems and different platforms. We thought about how we do it, why we do it, and what are the consequences, or even if we should do it at all. This has been a great discussion in terms of privacy and security of record linkage. And Patty notes that effective data linkage may be necessary, but it's not necessarily a sufficient step towards the reuse of data. And I think Alistair and Sam pointed this out in the fact that there's a significant amount of data harmonization that have gone into a number of the projects that you've been shown, and that is as critical for reuse of data as linking different data types together. Provenance is certainly critical to security, as is transparency, which incorporated the ideas of trustworthiness that we've heard. And there's a whole world of trustworthy repositories that are going in through the FAIR data principles and practices. And certainly technology and governance are separate, but equally important and should equally be given weight. I like the concept of who, what, how, and how these are all important. And also the ideas that participant contributors of data and information do make important contributions in the technology and the governance of data linkages and in its implementation, and that these do need to be brought to the table at the beginning of the meal and not far down after the main course has been eaten. And finally, special populations have unique needs and or identifiable data. We had a great conversation in the breakout I was in terms of the methylation of genomic data of indigenous peoples, that these do need to be taken into account when thinking about data and information linkages, and that privacy does not equal security. And some thoughts from Patty that she would like to leave us for tomorrow. We've had some really great discussions with both Tony and Pilar, bringing home the idea and the encouragement that data linkage deployed in better ways could characterize the lives of all of us, including those of the often underserved, and that effective record linkage has the ability to enrich our understanding and our human experience, and hopefully our data experience. After all, we're using this data to solve really important health problems like COVID and recover post-acute sequelae of COVID, and this is why we're doing it. And I think it's always important to keep in mind that we're doing this for a reason, and hopefully that reason benefits all. And with that, I will stop sharing my slides. And I look forward to meeting you again tomorrow, where we will have another wonderful discussion and 2 breakouts in participant perspectives and in ethics of record linkage. So we will meet again tomorrow at 1 p.m. You will join this exact same link, and the same situation with the breakout groups will occur, where there will be a separate link. And if you need any assistance, please do not hesitate to reach out to myself or to my colleagues in Deloitte. And thank you again. This has been a wonderful, wonderful discussion.
Thank you.
Thank you. See you tomorrow.
Yes, thank you. Bye.